And now it is my pleasure to introduce our first presenter, Assistant Professor. Assistant Professor Dr. Ambrose Wong. We're very excited for Dr. Wong to join us today to discuss his work on experience with bias and equity in the treatment of agitated patients in the emergency room, and how implementation of interventions, including trauma-informed care, can help to address this crucial issue. As just one example of his recent work, Dr. Wong recently published an article in the Annals of Emergency Medicine titled "The Coats That We Can Take Off and the Ones That We Can't: The Role of Trauma-Informed Care on Race and Bias During Agitation in the Emergency Department," which adopts the perspective of a medical resident who is himself a Black man to discuss observations of personal reactions to racial bias in patient treatment and the use of trauma-informed care as a tool to reduce bias in the care of agitated patients. So without further ado, I'm very pleased to hand things over to Dr. Ambrose Wong.
Good morning, everyone. Thank you so much for that introduction, Maggie. I'm really honored to be here. Again, my name is Ambrose Wong. I am an emergency physician and a clinician scientist and researcher at Yale School of Medicine. And I'm really pleased and privileged today to talk to you all about some of the work that our team here at Yale School of Medicine has done, as well as some of my colleagues across the nation, thinking about disparities and bias around the symptoms of agitation, which is a very severe form of disinhibited behavior that can affect patients with mental illness, personality disorders, and behavioral disorders. Just first, I wanted to acknowledge some disclosures. I do have ongoing research funding from the National Institute of Mental Health, as well as a couple of career development awards, but I do not have any commercial interests. So I want to start off with a video just to sort of get the juices going and to prompt a little bit for you to all think a little bit about what agitation may be like when it's exhibiting in the healthcare setting, and specifically in the emergency department. I just want to preface with the fact that the video is a little grainy and outdated, and it's also from the Learning Channel, TLC, so take that with a grain of salt. But it is unfortunately representative of sometimes what happens when symptoms of agitation occur in the emergency department and how healthcare members might respond, and also hopefully think a little bit about how bias may be introduced in these settings. So if we can start just playing that video for me.
Lay back. Hey, security.
Easy does it, friend. You call San Diego PD? Don't move.
I especially like the mullet on some of the staff members' hair. But unfortunately, as you can see, this video really highlights a number of problematic issues that come up when patients are agitated. And I want to highlight that in reference to some of the discussion points I want to make later on in this talk. So I want to highlight two specific points in my talk. The first, really going in a little bit more detail around what agitation is and how this particular symptom for patients with behavioral disinhibition and mental illness really can actually set examples up for bias and inequality when we try to manage those symptoms. And then the second piece is thinking about what interventions and solutions can actually help mitigate that, treat them in the patient-centered way, and specifically address bias and inequality when these symptoms happen, specifically for disadvantaged and underserved populations. And thinking about using a systems approach and using system science. So let's start with agitation and what that might mean and how bias and inequality can actually be introduced when we try to manage those symptoms. So what is agitation? And I think that actually in of itself, that question creates some problems as well. The official definition is any demonstration of excessive psychomotor activity. So someone who may be psychiatrically or psychologically agitated or physically agitated that leads to aggressive or violent behavior. And what we have found in our research as well as in previous studies is that it does have a strong link to individuals with mental illness, behavioral disorders, substance use disorders, and personality disorders. And this is one treatment algorithm that's trying to do this in a structured and rigorous way. So as you can see in the bottom level, when agitation symptoms might be mild, where there's some overt activity, but the patients are redirectable, we try to use verbal de-escalation and environmental changes to try to help get the symptoms under some more control. If we're at the moderate stage where now there's some threatening behavior, but they're not extremely active yet, then we may try to do a little bit more redirection, but at that point, oral medications and hopefully voluntary medications might be necessary. When we get to the severe stage, where patients are severely agitated, that might get to the point where someone is physically aggressive and violent, then at that point, we may actually have to use some what we call coercion. So that may be intramuscular sedatives or chemical restraint, as well as physical restraints, where we actually use straps and tie patients down with wrists at the wrists and at the ankles. Now, as you can imagine, when we get to these severe episodes, that really can be quite invasive for patients. We're talking about holding patients against their will and strapping them down in the bed. And this can lead to some lasting consequences, both psychologically and physically. And unfortunately, recent news articles and media focus on both police brutality as well as how we manage patients with behavioral disorders has really highlighted this topic. As you can see on the top left here, this was an individual who became very agitated as a combination of PCP or phencyclidine intoxication as well as mental illness. He did unfortunately get tased in the waiting room and actually suffered cardiac arrest and died. And on the bottom right, as many individuals in this conference probably recognize, Elijah McClain did receive an injection of intramuscular ketamine when he was handcuffed and restrained against his will in the field, and also subsequently passed away. So these are just some extreme examples of when agitation can go wrong and how some of these can have consequences, potentially lethal consequences for patients. What we found in our research is that although there are criteria for hospitals and healthcare institutions to report numbers and frequencies of physical restraint use in the healthcare setting, there actually are not any public reports of how often this is happening and who this is happening to. So we started just doing some research to identify what that's happening in our local shop, in our backyard, here at Yale-New Haven Hospital and the Yale-New Haven Health System. So we went to the electronic health record just to look how often this is happening and who are these people and why are these restraints happening. And as you can see, looking across 5 or 6 emergency department sites here at Yale-New Haven Hospital, we have found a staggering number of restraints. Between a 2 to 3 year period, we're talking about anywhere between 4,000 to 6,000 physical restraints placed just in the emergency department alone. And this is happening to a number of different patients, but specifically those with behavioral disorders, personality disorders, and mental illness are the ones that are at the most risk. We also wanted to talk to these individuals, and I'm really grateful that I have a chance to speak to you all, and especially individuals and family members with behavioral disorders. We wanted to give them a voice and also wanted to know what it was like for them to receive physical restraint in the emergency department. And not surprisingly, it was a whole host of negative responses leading to lasting consequences, anywhere from immediate fear and anger all the way to avoidance of the emergency department altogether and a disconnect with the healthcare system. And these are just some examples. Here's patient 12 who said, "My parents often drank and my dad would beat my mother. My older brothers would hide us or shove us in a room and lock the door. I also remember being sexually abused as a child. The little that I can remember, because I was very young, there was some type of restraint. And so I think that's the worst thing that can happen when they restrain me like that. A significant triggering of previous psychological trauma." Patient 7 said, "I felt like I was in prison, in the bed. I've never been to jail before, but my first experience of this was scary for me. I had never been restrained before. I had never had anyone hold me from my rights, I cried, I felt like I was alone in the bed with the straps on my wrists, my ankles." And this is just thinking about the fact that patients are coming to the emergency department oftentimes against their will, and really thinking that this would be a place that they would seek care or receive care. And instead of getting treatment, they're actually suffering more trauma and having harmful experiences. So, how does this gel or coincide with what staff members are thinking? And I wanted to highlight this article, which is actually from the New England Journal of Medicine, which was a great review article around the concept of workplace violence, healthcare workplace violence. And this is any episode where staff members are physically or verbally assaulted during their time of employment and they're working. And as you can see in this bar graph, the rightmost column, where there's a light beige, highlights the number of times that healthcare workers have missed work days because of a violent incident. And you can see this is 5 times higher than any other sector, including private and public sectors. And this is representing any institution where they receive state healthcare and social services. So this is clearly a problem in the healthcare sector. And we know that specifically in the emergency department, that is 5 to 10 times higher than any other setting. The media actually has also highlighted this, talking about the fact that frontline healthcare workers, specifically nurses, patient care technicians, are really in a very dangerous job. They are receiving violence at record rates, and hospitals are having trouble policing that and regulating that, tracking that, as well as preventing it. So when patients are telling us that they're receiving harmful experiences, that they're being held down against their will, that staff members don't understand them, don't treat them well, does that seem fair to staff? And how are staff thinking and perceiving this? So we also went to our staff members, healthcare workers, clinicians, as well as the security officers that work in the hospitals, to get a sense of what it's like for them when they take care of patients with agitation, with mental illness, and thinking about how they take care of that in the context of facing workplace violence. And what they're describing is a sense of this patient care paradox, the fact that they want to care for a patient in the best interests for them, but at the same time being threatened by these people that they're trying to care for. And so they almost have to choose between patient-centeredness and patient care versus their own safety. Here are some examples of quotes where staff members have talked to us about this care paradox. A nurse says, "I know that if I brought my family into the hospital to see, they would say, 'You need to leave your job.' For the normal public, it's very scary if someone is swinging a punch at you at work. But what if the underlying reason for the agitation is a head bleed? These patients are possibly the sickest, and they're so agitated they can't tell you what's wrong." Here's an attending physician talking about his experience. "While I would love to make things easier and say, go ahead, sedate and restrain them, I feel the need to take a step back and think, is this the sort of person we can try just a little bit more redirection? At the same time, I always worry about the safety of everyone, not just the patient, but staff and myself. I don't want any of us getting hurt, so it's a constant juggling act." And so one of the things we recommended was to actually identify this care paradox and think about workplace violence for staff and patient agitation and patient centeredness as one and the same problem linked together. And that when we think about interventions and solutions, those things need to actually be considered together and how these interventions might affect patient and staff at the same time. The other thing I wanted to bring up is the idea of disparities. And what we started to notice just working in the emergency department is that certain individuals were receiving restraint and sedation more often than other individuals. And this was at first just anecdotally from individuals who noticed it and just talked about it in circles with me. And then I started thinking about it a little bit more carefully when more staff were bringing this up with me. And so we started to look at this in a structured way. And these are just a couple of example articles that have shown this. The bottom two being work that was done here with our team at Yale New Haven Hospital. But as you can see, also in Mass General and other hospitals across New England that we're seeing this. And unfortunately, when we looked at physical restraints, who are getting these physical restraints, even despite the fact that we held control for patients with mental illness, patients with substance use disorders, or they're here for behavioral disinhibition, that regardless of that, we notice Black race and homelessness and lower socioeconomic status, as well as individuals with substance use disorders and psychosis, were getting disproportionately higher rates of restraint use than anyone else, than any other patients. And we started to wonder why this was happening and think about, is this something that we're doing wrong at the bedside? Are we all biased clinicians? Why is this happening to us? But you can see that this is happening in a large scale, not just here locally, but across multiple institutions. And so we wanted to create a framework to think about why this is happening. and we identified a socio-ecological model to describe why bias might happen around physical restraints. As you can imagine, at the patient level, there probably are some individual factors that do predispose certain people to maybe getting more physically restrained, maybe those who have lower thresholds for disinhibited behavior, or in an environment or milieu where they respond more aggressively to potential threat. But that's just not happening in isolation. There are layers of these things that are happening as we think about larger and larger scales. So, for example, for staff members that are interacting with patients, we know that bias, especially implicit bias and threat perception, can really be affected when they're being physically threatened or in a high stress environment. There have been some studies done just in the emergency department where we looked at doctors that are in training, and when they're undergoing more stress by seeing more patients per hour, they noticed that anti-Black bias is significantly higher post-shift. So not even just seeing particular patients, but it's the fact that they're seeing more patients per hour, getting more stressed, that anti-Black bias is seeped into their care and their thought processes. And so this is happening just between potentially patient and the clinician. And then at the institutional level, thinking a higher now, are there potentially organizational policies or the way that we think about where patients are agitated or protocols that may have implicit bias introduced in there just about how to respond. So staff members may just be using these protocols, but the protocols themselves are biased. And then finally, thinking even more large scale in systemic and structural factors, how are these patients coming into the emergency department to begin with? Are there potential biases introduced with police calls, with how patients are being brought and transported, who's being called upon, and also, like Dr. Axelrod talked about this morning, the fact that there are very few outpatient mental health services being available, and that those with lower socioeconomic status and potentially more marginalized race have severely difficult access to mental health and proper mental health services. So here's some example quotes from some of my colleagues, and as well as some patients who are minorities have talked to us about their experiences being Black, being minorities. So as a minority clinician managing agitation, as well as patients who are themselves minorities receiving restraint. And just a couple of domains really struck me, and some of these example quotes really raised goosebumps for me. For example, if the clinician is himself or herself Black, that really changes the perception of agitation and whether someone will receive physical restraint. So here's an example. I identify with patients. This is a Black clinician talking, and it really affects what I do because I'm a Black man myself. I think that's probably why nurses feel like it takes me so much a long time to decide. It's because I picture myself in their position. Here's a sense of threat perception and how Black race and the way that the mainstream media and culture thinks about Blacks can seep into decisions around threat. The exact story that gets told about, for example, the Black male who does drugs and then beats somebody up are magnified in a volatile situation like agitation. I would go so far as to say that I think there's a fear of physical restraint that's inferred mostly along the lines of a classically Black man. And finally, some pressures around interactions with staff members and patients and the milieu of the emergency department. Yeah, he has to get redirected once or twice more, but it wasn't someone that I felt needed to get restrained. He wasn't a threat to himself, nor was he a threat to anybody else. The nurse was actually not very happy with me at the end of the shift because I didn't restrain him. But in those experiences where I think people are already heightened, they already have a preconceived notion that the angry person, the upset person, the violent person is here. And that's really hard to pull back from the ship that's sailed. So a sense of momentum and a sense that there is some implicit antagonism against particular individuals, and that's really hard to pull back in that heat of the moment. As Dr. Davis mentioned, I was really fortunate to work with Dr. Isaac Egbola, who is himself a Black clinician and a Black resident doctor working here in the Yale New Haven Hospital Emergency Department. And he was the one who really said, this is a big problem, Ambrose. We need to think about this in a structured, systematic way. And so he is doing those interviews himself, and we're working together as a team to try to highlight this problem. And one thing that he talked about in the recent article that Maggie mentioned is a sense of trauma-informed care. So Isaac and I wrote this recent article in the Annals of Emergency Medicine to try to highlight this. The idea of trauma-informed care, for those who may not be familiar, is a sense that these individuals already carry long-lasting psychological trauma from the fact that they have borderline personality disorder and mental illness, the fact that they've struggled with bias and prejudice their whole life, that they have been potentially restrained in prior visits to healthcare, but also the fact that they may suffer more violence and brutality just from potentially more indigent upbringing, or just from suffering from mental illness. And that we need to think about those incidents of psychological trauma and try to prevent that from happening again when they seek care or when they interact with us. And what we've done here is mapped guidelines from Project Beta, which was a large-scale effort to present some patient-centered management around agitation, and how trauma-informed care can help us prevent biases. So, for example, even just in the sense of medical evaluation triage, sometimes we think about agitation as a symptom, but what if we think about the fact that patients and individuals are exhibiting these symptoms as a result of previous psychological trauma? So can we think about upstream effects of how that's leading up to what they're doing now, and try to acknowledge the fact that they have received previous psychological trauma as a way to recognize the symptom and to treat? And the other thing that I wanted to bring up is also for the staff members to recognize their own previous psychological trauma themselves. For example, we know that staff members who have themselves been physically assaulted in previous visits have a different threshold for how they think about threat and how they think about patients with violence. So recognizing themselves that they have psychological trauma and how that might affect their perceived behavior of agitation and thresholds for management, that can also prevent crises from happening and create better rapport between individuals that are coming to the emergency department seeking care and staff members. Just some food for thought. So again, just quick summary. Hopefully this was a good way to think a little bit about symptoms of agitation as a severe form of disinhibited behavior, and how bias and inequity can really be easily introduced because of the innate symptom itself. So I've introduced a lot of questions and issues, but how do we go about creating solutions? And what I want to propose is a sense of using a systems approach and system science to try to combat bias and also create solutions that are long-lasting and effective. So what does that mean, system science? And here is an example of when we think about problems that happen in healthcare. So let's say we found out that someone was biased, or that there was some bias introduced into one example of when someone was physically restrained. Whose fault is it? And often in healthcare, we think about doing what we call continuous quality improvement, which is really good and important. But a lot of times we start pointing fingers. Was it some individual that made an error? Where the problems lie? How do we go about fixing it so that it doesn't happen again? And in the current state where morale is very low, especially for the nursing profession, but really across healthcare, because of increased rates of burnout, and also a lot of people leaving the healthcare sector, and so we're creating a staffing shortage, it really has escalated the sense of burnout and frustration. And so sometimes it feels like we're just going to keep beating the staff until morale improves or until we find a solution. And one way to mitigate that is to use system science. And there's actually a whole field of individuals trained in systems engineering and human factors. And some very great experts have actually adapted that to healthcare, and specifically thinking about patient safety. So instead of thinking about the individual at fault, we think a little bit about creating an environment and a system that best supports individuals to work well within the system. And this is both healthcare clinicians and providers, as well as patients. So as you can see here, in the middle of this is the person, both the patient and the care team together as a whole. And we want to create a system that helps support that individual so that we lead to outcomes that are patient-centered for caregivers, family members, and patients. And this to me was life-changing. So I'm not thinking necessarily about how I change individuals, although that's part of the system, but I'm thinking about the larger scale of creating a big structure that continually changes and adapts to individuals, so that when times changes and culture changes, that we're still on top of thinking about that patient support. So we wanted to apply this systems approach specifically into agitation, and how we can use that to think about agitation care and create solutions. So we had adopted the socio-ecological framework that we talked about when we thought about bias, and mapped it to solutions at each level. So this goes anywhere from within the patient safety and patient experience of trying to help individuals cope with their disinhibited behavior. So this is just as simple as creating an environment where noise level is low, or giving them a chance to reprieve and find some solace in their symptoms. And this is maybe potentially having some drawing or having a milieu counselor who helps them cope with the symptoms while they're waiting for psychiatrists to see them. And then at the staff level, both creating support services for potential symptoms of burnout or the patient care paradox that we talked about, and then doing de-escalation training and specifically anti-bias training, which we'll talk about. And then at the team level, because we talked a little bit about some differences in opinion between staff members, how do we make it so that we create a shared mental model so that everyone is aware of potential biases and that we have the same plan of action for these individuals? And then at the clinical units and hospital level, thinking about creating process improvements and protocols that specifically think about bias and specifically are anti-bias. And then finally, at the larger macro system level, working with legal policies, law enforcement, pre-hospital services, so that we try to mitigate bias when we think about who's getting called and who's brought to the emergency department. And then finally, setting up transitions of care for mental health crises and for mental health and behavioral health patients, so that after they leave the emergency department, they get the right services they need and the outpatient care that they need. And this may include changing policies and laws at the state and federal level so that we better serve those patients that are the most underserved. So here are some examples of both what my colleagues have done as well as what we've done here at Yale New Haven as just some ways to try to combat bias. One thing that we have done here at Yale, as well as some of my colleagues in Boston, is to create de-escalation training that are both trauma-informed and anti-racist. So a lot of times, workplace violence training and training around agitation is focused on making sure the staff and patient are safe, which is very important. But don't think about the biases that can be introduced as we've discussed in the first part of the talk. So these are creating cases with standardized patients and oftentimes with individuals who themselves have suffered mental illness and behavioral disinhibition as ways for them to get a chance to meet a person and meet an individual one-on-one outside of the clinical setting. And then creating some experiences where the individuals can describe the biases that can be introduced, and doing some training for staff members so that they can be informed about how to apply these practices in real life. What we've also created in partnership with some of my colleagues in Boston are some specific ways to check your biases while you're at the bedside managing agitation. So for example, is there an actual threat to safety? Can we quantify that? Can we actually label what the behaviors are rather than using some potential ways to think about it in a subconscious way? Are there ways in which race, sex, and social identity have actually affected the way that you think about threat? For example, how is threat happening? And consider your own biases as you're making decisions, and then engage your team members in that discussion before you make a decision. And finally, thinking about the rest of your team. Do you feel supported in that process? And engage both security officers as well as your colleagues to think about how you're making that decision so that you're not doing this in isolation. What my other hat where we're at Yale is at the Yale Center for Medical Simulation, where we use simulated patients, mannequins, and situations to create realistic scenarios where people can train and work in a safe environment. And we do this for our medical resident doctors, nurses, and students. And one thing that we've done is to apply simulation-based training. And we've done this, for example, as you can see here, using a mannequin really to think about patient safety when patients are in crises and medical crises. But we've adopted that around behavioral crises as well. And this has worked really well for a couple of different reasons. What we've done, for example, is brought a standardized patient into the simulation center to do training for staff safety and patient safety. And here's an example where we have a standardized actor. This is a gentleman who is a milieu counselor at Yale Psychiatric Hospital who has acted as a patient for us. And we've brought our security officers, attending physicians, and nurses together to train together and talk through some of these issues. And what we found is that this really creates a dialogue to create a shared mental model around some of the concerns that they have when they're trying to make these decisions. And we also wanted to codify that and make that structured. And so one thing we've done for the past 2 or 3 years is created a code response team around patients that are agitated. One thing we noticed was that there was a divide in the thought processes around the security officers and what they thought was threat versus maybe what clinicians were thinking. And so we wanted to make sure that people were coming together as a team and thinking about it in a structured way so that we can prevent bias from happening. So we created some structured protocols, written protocols around what agitation is and when patients are called and what we do when agitation happens, so that we're doing it in a systematic way, regardless of what patients are and their skin or color of their race. We also added specific roles and positions so that not too many people were responding, and that we had individuals who had specified roles and would talk amongst each other and also share the dialogue. And we practiced it as well. We had actors come into the emergency department as a potentially agitated individual or showing symptoms of agitation. And we brought staff members who were on shift working to practice it together and talk through it. And then we would debrief as a team and try to break down where potentially communication errors might happen or bias might be introduced. And what we're trying to do is to change the perception of agitation. Because oftentimes when someone's agitated, especially from the view of a security officer, they think about it as a security threat. And they sometimes can transfer the thought process of what might be happening in the field as a police officer and bring that into the clinical setting. And oftentimes clinicians may defer to security officers when they respond to agitation. And instead of moving towards the right hand of the screen, we want to move more to the left. And sometimes there may be individuals who do perpetrate crime, but we know that by far and large, that's a very small minority, and that most patients coming in are in behavioral crises, they need clinical help, and they need a clinician to respond. So we want to make sure that we move the compass more towards the clinical thought with security officers supporting, but that we're thinking about the clinician helping a patient or an individual rather than thinking them as a perpetrator of crime. And as a result of some of the work that we've done here at New Haven Hospital using the code response team and training, we've actually seen a marked decrease in physical restraint use, which we're really excited about. So we launched this in 3 phases. The first phase here is a pre-implementation phase where we just did some baseline calculations of what restraint use was like here on the far left corner. And then in the middle, we started doing the designing and the administrative support and training. And even just with training alone, we started to see a trend in decrease in physical restraint use. And then when we added the code response team and the additional simulation training, we saw a continued decrease in restraint use as well. Even despite through the COVID pandemic, where we knew that mental health crises were escalating and that patients with psychiatric issues were coming to the emergency department even more often than before. And the last piece is thinking a little bit about debriefing. So we've actually added QR codes outside of behavioral crises rooms and resuscitation rooms, so that after a particularly challenging episode of agitation or mental health crises that we're managing, the staff can anonymously respond and give feedback to us so that we can incorporate that into future training and into our code response team. And the other thing that some of my colleagues in Boston have introduced are patient debriefs, which I think is really exciting. That a social worker or a clinician goes to a patient after this has happened within 24 hours, after they've got their restraint removed or after a behavioral crisis has happened, and try to use some trauma-informed principles to debrief and talk the patient through their experiences so that we can incorporate patient feedback into our training and to our future work. So in summary, hopefully this was a good, quick, high-level review of agitation. The first piece is that agitation is a unique symptom in healthcare that really introduces bias and inequality. And some things that can combat this are support staff training so that when they make decisions under stressful conditions, they're not potentially prone to bias, and that we create structured standards to manage symptoms. And finally, thinking about how we can apply the systems approach to try to mitigate bias. One thing we wanted to do was apply trauma-informed principles and anti-bias training for clinicians, and that team-based approaches can hopefully de-emphasize the criminal or the security mindset of agitation and agitated individuals. Thank you so much for your time, and I really appreciate your attention. And again, I'm very honored to speak with you all today. Thanks again.
Thank you so much, Ambrose, for that incredible presentation and for highlighting such a sensitive yet really crucial topic. And unsurprisingly, the audience has a lot to say and a lot of questions for you. So to start you off, the first question. Dr. Wan, I attend a Family Connections training weekend, and there was an emergency room physician who stated, I just can't expect ER doctors to know anything about BPD, and I want to know why that is and what is going to be done about it.
That's interesting. I'm curious to know which emergency doctor said that. I think my feeling is that, unfortunately, mental health training is not formally incorporated into emergency clinical training. We do rotate through the psychiatric emergency department for either 2 to 4 weeks as part of our clinical rotations. But I think what we can do is emphasize mental health crises and mental health training a little bit more formally into our emergency medicine training. Oftentimes, I think we think about medical crises as potentially being more important or maybe sicker than patients coming with behavioral crises. But what I'm recognizing myself just doing this line of research and interacting with individuals with behavioral crises is that they're in just as a dire situation. And they may not necessarily demonstrate it in vital signs or maybe an appreciable physical thing that you can actually touch. But the symptoms they're exhibiting psychiatrically are ways that they manifest symptoms. And I think we have to shift the dialogue, and that's really through training and exposure.
I think you've already spoke to this a little bit, but following up on that, do you educate staff about BPD and how agitation related to BPD symptoms may present and how to react to and de-escalate the situation with compassion? And the person also said, thank you for your work.
Thank you so much. I think that's a really fair point. I would say that there are a lot of ongoing misconceptions around personality disorders in healthcare, and specifically, I think, borderline personality disorder. And I think there's a lot of lack of knowledge around what personality disorders are and how symptoms of personality disorders can manifest both during agitation, but also during an emergency department visit. What I have found to be really helpful is to bring clinicians and professionals around personality disorders like yourselves and your group and liaise a little bit more closely with emergency clinicians. So I think that's actually really important as well, because I would have to say that I'm also not a formal psychiatrist or mental health professional myself. And oftentimes I'm looking to my colleagues for their expertise as well. So what I want to do is try to use examples like this where we can share dialogue, both share research, but clinical experience and lived experience of individuals, so that I think emergency care professionals get to see that in action and also understand what it's like for patients and individuals to experience these when they're not necessarily at the bedside, but when there's sort of a calm environment where we can have a shared dialogue. So one thing we thought about is to actually bring individuals to staff members during training so that that dialogue can happen.
Great. Okay. Someone here wondering if restraint episodes are always documented in the ER.
Yes, they are. The federal regulations require the orders to be placed and that a clinician evaluate a patient within an hour of when that happens. And there needs to be some strict documentation around why restraints are needed and how we minimize use of restraint. So that's pretty stringent and codified in the federal regulations.
Okay. We've only got about 1 minute left, so I'm going to do a final question. Would you think that BIPOC clinicians initiating care with BIPOC patients agree that patients need to self-identify, but sometimes clinician assignment may happen before that conversation can take place, particularly when the patient is agitated?
That's a really good point. I think in practice, it may be difficult because the emergency department is big and there may not necessarily be any structure as to where patients are being placed, so that we can match a minority clinician with a minority patient. However, I don't think that's impossible. For example, oftentimes a lot of minority clinicians are actually self-identifying. They noticed a patient who is a minority who's suffering, and they either go and volunteer to pick up the patient and care for them, or they intervene. Although some of my minority clinicians have remarked that that's really a minority tax in some ways. It's not necessarily part of their scope, but they feel empowered and also feel responsible to help those individuals. And I think we talked a little bit about system science. I think we should actually somehow make that happen in a structured way to match the clinician with the patient so that those cultural relations can happen. The other thing that my minority clinicians have mentioned is that we actually need to hire and recruit minority individuals much more so in the clinical settings, so that experts and clinicians are themselves minorities, so that we can do that in a structured way, because there's just not enough minority clinicians to do that right now, unfortunately.
Thank you so much, Ambrose.
Thanks again.